be able to address us. So I'll just do a quick introduction. Dr. Adari, retired colonel in the Army. He is a surgeon who's based in Nairobi. He's a retired military officer. And his practice is mainly arthroplasty and arthroscopy, and therefore also sports medicine. And recently he says that he has developed an interest in regenerative medicine, more precisely orthobiologics, which encompasses the use of platelet-rich plasma in orthopedics. And so I guess he is the right person to be able to talk to us about this today. So Dr. Adari, welcome. Please share your screen and take us through the talk for today. I'll request anybody who has questions along the way to please post your questions in the chat so that we can go through them at the end of the 30 minutes that Dr. Adari will be talking. Welcome, Dr. Adari. Dr. Adari, kindly allow your audio to be joined by audio, and also you can share your screen. We will be patient as Dr. Adari gets his volume and everything back on. But in the process, don't leave the meeting. Dr. Adari, please join the audio. You have not joined audio, so you'll not be heard when you speak. Please unmute your microphone, Dr. Andari.
Hello? Yeah.
Thank you. Now we can hear you.
Oh, thank you. So are we ready to move on?
Yes, please go ahead. You have 30 minutes and then we'll take the questions. The questions will be shared in the chat. So we'll read through the chat at the end of your presentation.
Oh, thank you very much, Dr. Nguku. Sorry about the hitch of technology that tells stories about us. So as may have been introduced, my name's Colonel Dr. Adari. I'm a retired military officer. I'm a fellow colleague in orthopedics, and I was requested to do a presentation, and we share what we go through in our practice. So I chose a topic of PRP in orthopedics, which is fairly, I'll call it a topic of generating a lot of interest because there's so much that is going on now in the world of orthopedics, and we can no longer stick to what we call the traditional life or which we've led all along. And this I refer to my senior colleagues and my contemporaries. So I chose PRP in orthopedics, and PRP by definition basically refers to the plasma fraction of whole blood that's been enriched with platelets above the baseline. This is among the biological products which are now used in various fields, and more precisely, it's regenerative medicine. And so for our interest as orthopedic surgeons, we look at what is orthobiology, use of cells in our practice, day-to-day practice of medicine. And to this end, PRP, as I mentioned, is one of those cellular treatments that we are seeing gaining a lot of prominence in our practice. The others are bone marrow concentrates, in which you try to get a yield of mesenchymal stem cells. And this mainly occurs, you'll find a lot of people practice this by harvesting the mesenchymal cells from the iliac crest in the form of bone marrow concentrates. Another great source that is known for mesenchymal stem cells is from the adipose tissue. It's considered to probably have one of the richest stores, so to speak, of mesenchymal stem cells. And most people would then go to the abdominal wall, and some would go to the gluteal region, depending on where you're able to get enough of that. PRP may be used independently or as an adjunct treatment. And examples that we look at, for example, matrix autologous chondrocyte implantation, which is one of these surgeries we'll do as a way of dealing with osteochondral defects. This has gained a lot of significance in the knee lesions. Also, there is a role of use of PRP in ACL reconstruction. Again, this is just an augmentation treatment after you've done the basic treatment of ACL reconstruction. The other bit, again, is in rotator cuff repairs, tender Achilles repairs, and so forth. I'd like to touch a bit on the biology of platelets. As we all know, and this is something we've gone through in med school, that platelets are basically cytoplasmic fragments of megakaryocytes that are found in bone marrow. On average, they have a diameter of about 2 micrometers. These are enucleate cells, and they have numerous bioactive products and organelles. Suffice to mention here that platelets have a very short lifespan in the bloodstream, about 5 to 9 days. After that, they are cleared from the bloodstream. and this is mainly by the Kupffer cells and the hepatocytes. By shape, and this is normally in the, what you call in the dormant stage, when they're just floating in the blood, they are either discoid in shape or ellipsoid. And what has been shown is that platelets have got 3 distinguishable zones, what you call the peripheral zone, the organelle zone, and the cytosol zone. This is significant only for purposes of trying to understand how platelets carry out their roles in what we know about the cellular mechanisms in which we use the platelets for our purposes. A little bit about the peripheral zone, because it contains antigens and glycoproteins and also various enzymes. The other zone is what's called the organelle zone, and this contains the dense granules, the alpha granules, and I'll talk more about the alpha granules, Golgi apparatus, lysosomes, and the mitochondria because of the energy that we also need within the cell. In our situation, alpha granules are very significant here in the sense that this is where we have the growth factors that modulate tissue repair and healing. Examples of that are many, and one is we think about the platelet-derived growth factor, what you call the transforming growth factor beta, and many others, just to show you a few of them that have been isolated and have got different roles. If what we are seeing at the center is the platelet granules, then you can appreciate the various growth factors that are all, but they are different, and I think from the description you can see the kind of the kind of involvement they have in our system. We'll get into a lot of details specifically as we go on. The functions of platelets are mainly, if they can be grouped, 2. The principal function of platelets, of course, we know is hemostasis, and this is what we've always known. The endothelial wall damage will expose the collagen, and this activates the platelets in a setup of an injury. For instance, what we see, and this is an example I give many times to my patients, that you got a little cut on your hand, you'll bleed for 3 to 5 minutes. Thereafter, the bleeding stops. Whether or not we press it, or as we normally think by pressing, we are stopping the bleeding, but the actual sense is that it's the platelet action that takes over, and we get a platelet plug, which will lead to clotting, and that's how we stop the bleeding, or we stop losing blood. It's also been shown that inflammation per se can activate platelets. And this is important in our circumstances because we will see that we can use platelets in an environment of inflammation to activate so that we are able to access, so to speak, the growth factors that are useful for purposes of healing. So the other function of platelets, of course, is initiation and promotion of tissue healing. And this is best demonstrated in wound healing, just as well as we see it also in fracture. And we will remember the various stages of either fracture healing or wound healing, inflammation, cell proliferation, and angiogenesis, the new vascularization, and finally, then we have the remodeling or the maturing of whether we are dealing with the bone or we are dealing with the cartilage tissue or we're dealing with collagen in terms of tissue strength. We see that also in wounds. Now, in the production of those factors, we know that upon platelet activation, the alpha granules have been shown to fuse to the cell membrane of the platelets, and this is what we call the degranulation. And the secretory proteins, thereby, as these examples that I'm giving here, then get into what we call a bioactive state. Once this happens, they bind to the transmembrane receptors of the target cell. Examples of the target cells, because it's been shown that PRP is effective in connective tissues. And these are of mesenchymal origin. And this is where we look at mesenchymal stem cells themselves, being the target cells that can be modulated by the growth factors that are produced by PRP, osteoblasts, fibroblasts, endothelial cells, and even epidermal cells. It's worth to mention that in PRP, it's not only the platelets, we also have an amount of white cells within that concentrate, as well as other blood components that all together work towards what we will see as the benefits of platelets. It has been shown that an ideal concentration of PRP that would have a clinical, what you would call a clinical impact, should be something to the tune of 1 million platelets per micromole in a volume of 5 mils of platelet, also plasma. And this is considered to be effective treatment using PRP. Of course, when you read in literature, there has not been real consensus into what should be the ideal, or what you would call, what should be the amount of cells you need to give you a clinical picture that you can say, indeed, PRP has influenced this outcome that I have in whatever condition I'm dealing with. But all these are what we see from various practitioners in the field of regenerative medicine, and particularly in orthobiologics. Now, a little bit about history of PRP. This, when you look at the literature, this science has been on since the 50s. But in the 70s, the hematology was seen as the leading area in which PRP was used in the treatment of thrombocytopenia. Then all was quiet. About a decade later, maxillofacial surgery took in and was using it during their procedures. Sports medicine and orthopedics came in later, and that is in 1990s. And this has really grown. If you go into look at the literature, it's awash with a lot of studies and a lot of data about the use of PRP, the efficacy, the shortcomings, and what are people seeing as the future of orthopedics using cell treatment. Come to 2000 on, then of course the cosmetology has really come in as a way of using. They use a lot of PRP for their various management of issues of cosmetology. I'd like to share a little bit about how we do the preparation for PRP. There are various commercial scientific kits in the market, but bottom line, or the basic thing, is that the centrifuge machine is able to separate the cells based on their specific gravities, which are all different. So you will find, for instance, you are able to do what you call a single spin. And a single spin, I'll give you an example of what I use, is you take about 15 mils of blood, put in a specialized double syringe, and spin it for 5 minutes, at the end of which you'll have two layers. The top layer, which is pertinent, will be mainly what you call the plasma. And the lower layer will be seen mainly as red cells. Of course, within that, you then have the other heavier cells like the neutrophils. So the order is usually, the topmost will be pure plasma. The next level will be the platelet level. And then in that order going down, you'll have the monocytes, the lymphocytes, neutrophils, and the lowest being the RBCs, the red blood cells being the heaviest. There are other commercial kits again in the market which use what we call the Peripheral Zone. They have a gel which is able to completely separate the red cells from the rest of the cells. Then all these are refined products that purely trying to give you further separation of the PRP. And you may have heard what now goes on as leukocyte rich, leukocyte poor, and even those are considered to be useful for various treatments so that it's no longer uniform or one fits all kind of treatment using PRP. This is just what I've referred to. Of course, in the leukocyte-rich, it's been associated with a lot of inflammation and a lot of catabolic effects going on at tissue level, while the leukocyte-poor is more of an anabolic mechanism. And so a few authors like Johannes have suggested that leukocyte-rich PRP should be suitable in the acute injury, acute soft tissue injuries. And another fellow Zone with his team hypothesized that the reason for that is in leukocyte-rich that we have the leukocytes, they help in the fight for infection. And for example, in wound healing, that might be really necessary in the initial stages. Come to the other end, where you have the leukocyte-poor PRP. This is thought to be better in the chronic phase of any kind of tissue damage. For example, if you're dealing with some old standing epicondylitis, or you're dealing with tender Achilles tendinopathies, that you might be, or patella tendon inflammations, you might be better off with a leukocyte-poor PRP. So more specifically in orthopedics and in sports medicine, what we see is, as I mentioned earlier, is their use in tendinopathies, and examples that come to mind is patella tendinopathies, or the jumper's knee, lateral epicondylitis, the what you call the tennis elbow. These people who have chronic pain in those areas, it's been shown that the use of PRP is much superior to the use of what we have always relied on, the corticosteroid therapy. And this, again, we see in ligament injuries or ligament pathologies, for example, the plantar fasciitis, which traditionally we have treated using steroids. Same goes for in SC reconstruction, or if you have LCR injury, partial injuries. Personally, I have used PRP and followed patients to see the response. And indeed, I would say some of the patients I've so far followed, I didn't have to go ahead and suggest surgery. The same is seen in MCL repairs and in partial tears in rotator cuff. In muscle injuries, especially in sports of the athletes, you get a lot of proximal hamstring tears or sprains. Again, use of PRP has been shown to be superior to the use of anti-inflammatory agents like the steroids. In bone, non-union, in the delayed union, again, PRP has been shown to offer or to stimulate the repair. Cartilage, we think about osteochondral disease or the osteochondral disease defects. And to date, osteoarthritis, particularly of the knee, if you go into the literature, it's taken a very central position in terms of use of cell therapy. Routinely, because PRP is easy to prepare, it's easily accessible, and is an office practice. A lot of us, and when I went for one of the conferences that was doing a lot of data presentation and the way forward in PRP and other forms of treatment using cell therapy, it was shown that so much has gone on in the osteoarthritis of the knee, to the extent that now osteoarthritis of grade 1 to 3, basically you use PRP, or you use the bone marrow concentrates, or as I said earlier, the adipose-derived mesenchymal stem cells, to manage the osteoarthritis, as opposed to what has always been a way of dealing with the osteoarthritis in the past. Yeah. So I would say that looking at what we have, we are moving on to an area which, as any new science, they are the nays and the eyes. What will get us, what we can say is there's so much pressure on the practitioner today, whether or not we like it. A patient will come to see you when they have Googled everything that they can from the Dr. Google, or they have been to several other countries, or other friends from other countries who will tell you, but have you heard of cell treatment? Have you had some people come and say, do you do stem cell treatment? And yet these are just things that bog our mind, and we say, can we continue to do things the way we've always done? And I think, in my view, the answer is no. We have to try and adapt to what we are seeing all over the world as new ways of trying to deal with the common conditions that we see in our practice. Having said so, I would like to look at, with all this, what are the limitations of PRP? One, it is a type of treatment which is target specific. You must place it exactly where the problem is. And this calls for some extra input in terms of skills that you need. You need to learn to use ultrasound guided treatment so that you're able to place the cells where the damage is. In some conditions, you may need to rely on the fluoroscopy, the image intensifier that we use a lot in our practice. Other limitations, and which are quite significant in this manner, is there's absolutely no consensus among the practitioners on the right dosage, as I said earlier, of PRP that you can say, this is what works, so that we can use the same to compare our results. And it will not depend on the practitioner and what he does. For instance, when I went to the US in 2019, you find one speaker talks of giving PRPs consecutively every 3 weeks, 3 times, to achieve, and this year they're talking about osteoarthritis of the knee. Others do it at an interval of 6 weeks, and others every 5 days. So that just shows you that different people use different techniques, and use different methods. At the same time, the way of harvesting the PRP also varies because of the different machines that are in the market that give you these yields of PRP. So this remains a controversial thing in our practice. But we hope that with time and with a lot of research going multi-center and having a lot of the level 1 kind of evidence in what we are doing, then PRP and many other cellular treatments probably will become part of our armament in the course of managing our patients. Unfortunately, the only way to do this treatment is through an injection. And of course, we know with every injection, particularly if you're a joint, we run a high risk of introducing bacteria into that joint or any other organisms, and you may cause septic arthritis or any of those infections into the joint. So this is a potential risk that is seen. And so it calls for a level of aseptic technique as they're doing this procedure. We don't see it much, but it's something which is known can occur. So far, if you look at the literature, the numbers are very small in any one center where this is done. You'll find around 20 or 30 patients who are being followed up. So the statistical significance of this kind of data is one thing. And one wonders whether indeed there are those who don't believe that PRP works. One of the other limitations that this I found when again I went for this training that has been overcome by, of course, by the countries like the US, where you have a lot of government funding and support, is that there's very little outside such countries unlike in our country where you can be able to say, while you are doing your procedures, you will be able to do it as a way of collecting data and placing at a research study and really be able to put up a case for what you're seeing among your patients. Not to mention that even in our practice, cost is an issue, and this is because one, to pay out of pocket is straining to a lot of patients. In any case, as I've said, a lot of this PRP use is in early osteoarthritis. The old who are victims of this kind of problem do not have insurance. Probably the only thing they have is an NHIF, which doesn't pay for such cases, as they consider this to be still treatment that is in its experimental stage. So with that, that's what I had for you, my colleagues. I would be happy to hear your questions, and maybe that will storm our discussion, and any areas that I haven't touched, we can be able to share. Thank you very much.
Thank you, Dr. Adari. I've not yet seen any questions in the chat, and so I will maybe start off with a question as we wait for the others to wrap around their minds around this PRP. You have mentioned that there is still no consensus on dosages, but since you have been in the practice, you can tell us about the dosages, because so far you talked about getting 15 mLs of blood and spinning, but we don't know how much you end up giving to the patient, how often, for what kind of condition, what do you do for knee arthritis, what do you do for the tendinopathies? Maybe you can just give us a brief on that.
Thank you very much for that question. Yes, in my practice, where the kit that I have two kits, one of the kits that I use, if you draw a blood 15 mils, you'll be able to get a yield between 3 mils to 5 mils of PRP. And according, of course, this is based on the manufacturer, says that should be the amount of cells you get in that yield should be directed to one particular site where you're doing the treatment. Assume it's the knee joint. The thinking is you should have an average of around 200,000 platelets per micromil of the plasma. And so if you're talking about 300, if you're talking about 3 mils or 5 mils, then you can compute that and you see the amount of cells that we are able to do. And that I use a lot in early arthritis. I use it also in patients with rotator cuff tendinopathies, patella tendon, and I use it in, as I mentioned earlier in my discussion, in epicondylitis. Now, the other kit, which I have, that one is from Israel, is the Bafficort. That one you need to take, they have two kind of syringes, the two kind of test tubes in which you draw the blood. One is 11 mils, the other one is 22. For the 22, you need to use large joints like the knee, but in areas like around the tendons, then you need just about 11 mils of blood. And that again will give you 5 mils in the 22 mils of blood and around 3 mils in the 11 mils of blood.
When it comes to administration, what's the frequency? Are you doing that every 5 days, every 7 days, every 6 weeks?
No, as I said, cost remains a handicap in this, but on as a routine practice that should allow me to be able to assess how patients, I do it every 6 weeks, and I do a total of 3 doses when I'm dealing with osteoarthritis in the early stages. And after that, I just follow my patient. And I'll be able to say, I started this treatment, doing this treatment from 2017. In 2016, we were just going for some arthroscopy training in Germany by one of these chaps who were coming to the country. And then by the side, we were taken through the PRP, that it's no longer a lab story, but something used in clinical practice, particularly in Europe and North America. So it's out of that I picked the interest, and then I followed it up, and we were able to get a few machines in the country. I think there are about, so to speak today, maybe about 10 machines in the country from the same company. And people are doing, but for my case, I go every 6 weeks. There are many patients who you just do treatment once, and the next time you'll see them is probably after 8 to 10 months, and it should be the contralateral knee. This knee will have been quiet for that period.
Just one last question before I go into the chat. I was scanning through the list of participants, and I've not seen any of the Kijabe sports team. So let me ask a question on their behalf. I remember before I left Kijabe, there were a few patients that we did PRP on, and one of the things that concerned us was the immediate post-injection pain that they would have. Of course, it would subside, and eventually the tendinopathy, or let's say the tendinopathy, would go. Have you had any such experience? And do you end up mixing the PRP with anything else because of that reason?
Well, yes, I have experienced that. But what I've done from the beginning is I usually use a little bit of local anesthetic, that is 2% lignocaine, just at the skin level, at the entry point, and a little bit of Macaine, probably up to a cc or two, because the thinking is lidocaine and even Macaine, because of the acidic media, tends to interfere with the release or activation of the growth factors. But that is something I've noted. Some patients will develop extreme pain thereafter, but as I said, I've just gone around it by giving a bit of local anesthetic, and then I release them on paracetamol, because the thinking again is do not use NSAIDs, if possible, a week before and 2 weeks after the PRP. Of course, in our circumstances, that's a bit difficult. By the time the patient is coming to see you, they're literally having bags and bags of anti-inflammatory agents with them because of the pain they are in. Yes.
Okay. There's a question from Dr. Samuel Wafula. Thank you, Dr. Adari, for the awesome presentation. Any experience in your practice with the PRP used in non-union and delayed union? And do you have to augment with any other modalities?
I've used PRP in delayed union, not in non-union, delayed union, and basically because these patients should be having pain a little longer than the time you'd have expected them to have as if the bone had healed. So we think that in this case, really, we are dealing with delayed union. And what I've done is given an injection into that site and followed those patients. And indeed, some, I think I can think of around 3 patients in whom I've done that. You follow them up, and whether the PRP is what changed the circumstance or just the irritation that you put in that area that provoked what you'd consider as new healing going on. But later on, you find these patients go into full union, develop colors, and then they're able, the pain is actually contained.
I don't see another question, but I'm just wondering, this is something that you've done over the last 4 years. 4 years is way more than many of us, way more experience than many of us have had. Would you maybe suggest some resources that people can access to train in this? I'm seeing Dr. Wafula's question on the non-unions and delayed unions being very relevant to a lot of orthopedic surgeons out here who are dealing with all this trauma. Maybe not as many may be dealing with the tendinopathies, but so many of us address trauma. And I'm just wondering how many other patients would we end up saving from having nails in them if this is a modality that could assist?
Yeah, I can,
post in the chat.
what I would say, there are 2 main teams I can think of. There's a team that invited me in 2019. They are called TOBI. TOBI, something I look in the TOBI, the Orthobiologic Institute in the US. They have quite a lot of funding, when I was making that reference, is actually the Toby that I've been given so much to go. And they are very keen, because this is now a science, they're really trying to expand its use, to take in those who would go in as fellowship. So when you go into the website, you'll find the kind of scholarships they offer to those who are already orthopedic surgeons or are in practice, and residents, and those in the military. So they have all those groups, and they would offer you. So you may have to probably look for something like the ticket. I'm talking of before we had all these problems with COVID, where traveling has been an issue. Mm-hmm. But even then, right now, there's quite a lot of virtual training going on regarding PRP and its usage. So I can share that at a forum where you can be able to get this help.
Okay.
And to me, I think it's a way that I would encourage most people just develop the interest, and you will be able to tell for yourself really that it can help in certain situations where you think you don't want to intervene again in a patient surgically. Yeah.
Let me ask an unfair question now. We know the costs are high. Maybe one, you can start with telling us what would be the cost of preparing this. I know most of that cost might be going into getting the machine. So that if a patient is to have 3 of these injections, what would it cost them? And then secondly, is there a local way that we can find of bringing down those costs? For example, we are talking of having a centrifuge. Can't our labs do that for us? They already have centrifuges. Which way can we bring down the costs?
Let me start with the second one. I think it is possible for our local labs to help us, because what these guys have done is to calibrate that centrifuge machine specifically to be able to separate those cells based on specific gravity. And I believe that is something we can be able to do for ourselves. Now, coming to the first question, I'll talk for myself. I do not know if my colleagues, but I know 1 or 2 of my senior colleagues who went with, who as this company was starting the process, they made this and they said, you'll buy syringes from us. They call them syringes, the double syringes.
Yeah.
As you buy the syringes, we'll charge you the cost of the syringes, and we'll cap it up as a way that after some time we are able to recover the cost of the machine. So we'll just put that machine in your office like a lease.
So it's a lease, really?
It's a lease, because if you are to spend money on it, I don't think you'll have a return of investment even after these 3 years, because it's expensive. And again, it is really for specific indication. You can't really be using it like you want to get your money back, and so extend the indications. So on average, you'll find per treatment, the patient will part with something like 20,000 because of the little, let's put it, the sterile packs that you need to use yourself. You'll start a little procedure on it, and the company will sell to you on average about 13 to 14,000 shillings per kit. So you add up that, and that's what I'm saying. When a patient is adding up to the consultation and so forth, it will be something that will range to around 20,000 shillings. And of course, you can see in our community, that's quite an expensive undertaking for anyone coming to an outpatient facility. Yes.
Yeah, especially now when you compare with the taking NSAIDs or something else simpler, which is what they would be at that time. Yeah.
Yes.
Well, I don't see any other questions, so I'll say a big thank you to Dr. Adari. Thank you for helping us to move to another step in putting some technology into orthopedics, not just fixing bones. Thank you very much.
Thank you very much, Dr. Nguku, for that moderation. And I hope this will just stimulate discussions, and we can have many more at local levels or just reaching one another.
Yeah.
Thank you very much.
Welcome. So I'm informed that today we didn't have a sponsor, so there'll be no sponsor coming in to talk. And I'm also informed that we don't have any new announcements. So I don't have any announcements apart from reminding us that the conference, the scientific conference for this year is currently still postponed to a date that will be confirmed to us at the future. So thank you all of you for attending, and have a good evening.
And I thank you very much for listening to me. I look forward to more interactions.